Hey, this is Courtney Forehand. I'm a nurse practitioner student with Auburn University. This is a 5-minute video talking about peritonsillar abscess. So peritonsillar abscess is a complication of pharyngitis or tonsillitis that manifests as a cellulitis and develops into a collection of pus between the palatine tonsil capsule and pharyngeal muscle. Common pathogens include Group A beta-hemolytic streptococcus, Streptococcus aeruginosus, Staphylococcus aureus or MRSA, and Haemophilus influenza. Most common incidence is in children and adolescents, also young adults, with most common age being 15 to 30. What puts people at risk? Concurrent or previous pharyngitis, tonsillitis, or supraglottitis, mononucleosis, penetrating trauma in the nasopharyngeal area, and smoking. Other risk factors are cold and flu season, age, immunosuppression, chronic colonization of bacteria in the tonsils or adenoids. Questions are essential to ask in the workup. You should ask, have you had a recent or prolonged strep throat or pharyngitis, trauma or surgery to the nasopharyngeal area? These findings put the patient at higher risk for developing an abscess. Ask, do you have severe unilateral throat pain and a muffled sounding voice? These findings are more specific, indicating the chance of an abscess forming. Ask if they're having trouble swallowing or if they're having painful swallowing. Ask if they're unable to open their mouth fully or have had a fever or swollen lymph nodes. These are more specific findings for peritonsillar abscess. Some physical exam components: assess vital signs, particular presence of fever, assess respiratory rate and oxygen saturation, a full HEENT assessment to assess for peritonsillar abscess as well as any associated findings such as an otitis media, conjunctivitis, and rhinorrhea, swelling of the face, bad breath, or postnasal drip. Careful examination of the throat. Have the patient open their mouth and say ah. Use a tongue blade if necessary. Check for unilateral tonsillar swelling and pus accumulation. It is very important to note the uvula and any displacement, as this is a red flag and would indicate risk of airway compromise. If uvular deviation is noted, this patient needs to be admitted possibly and consulted to the ENT for drainage of the abscess. Careful examination of the neck. Check for cervical lymphadenopathy. The lymph nodes that are enlarged are usually on the same side of the abscess. Examine how the patient sounds when he or she speaks. If there's any drooling or trismus or stridor. If the patient has a peritonsillar abscess and the swelling is constricted, constricting the airway, the patient will have what's known as a hot potato voice. If the airway is compromised, you may note stridor. Some common treatments. Non-pharmacological would be just an inpatient admission if the airway is compromised. Fluid replacement for dehydration. Acute surgical management would be a needle aspiration and removal of the abscess material. Pharmacological would be antibiotic therapy, parenteral until afebrile and clinical improvement is noted. This would be ampicillin, sulbactam, clindamycin, or nafcillin. And then you would transition to a minimum 14-day course of oral antibiotics. Less than 10 days is associated with reoccurrence. This would be augmentin, clindamycin. The dosage is noted there. Anti-inflammatory drugs for larger abscesses to reduce swelling and pain. This would be steroids or NSAIDs. And the prognosis is complete recovery with a 10 to 15% recurrence rate, increase with history of recurrent tonsillitis prior to the abscess, and the recurrence rate is higher if the abscess is not drained. Some priority teaching components: teach the patient that in order to prevent an abscess, it helps to begin treatment for tonsillitis or pharyngitis immediately. The chance of getting an abscess increases when you delay treatment. During the treatment for a peritonsillar abscess, you need to teach them to stay hydrated and monitor the airway closely, especially in children. If the airway becomes compromised or the patient becomes lethargic, it's important to teach them to go straight to the emergency department. A tonsillectomy may be indicated if frequent infections occur, but this would be done after the infection has resolved. And that is the end of my 5-minute video. Thanks so much for watching.